I'm Dr. Yasmin. I'm running my courses on Mrcog, and that is part 2. Now it is the recent advances in endometriosis. Okay, what treatment you will do for endometrioma when you are planning for the patient for infertile infertile patient, for patient who is going for ART, patient who is unmarried, she's not planning. So different questions are there, and definitely this time question will come. So there's a two is there. One is the SIP. They have done second edition of the SIP. So previously it is not valid now. This the effect of surgery of endometrioma on fertility 2025 second edition. So this one is valid. Another one is not valid. Okay. Next one is what new in guidance. That is by the talk. So first we will do talk, and then we will do. Just a minute, my slide is not changing. I'm audible, right?
Yes, you're audible.
Okay, sorry, that goes fast. Now, these are the dates for the exam. Everybody should know. You have to send the expression of the interest. This is must, and it is up to 9th September. So, better to fill today only. Even you will not book the exam, send this. Booking window application open on the 21st October, and same day try to do booking of your exam, because this is must. Otherwise, you will not get the center nearby you. Booking window closed 9 December. Exam date is 15 January, and result release on 11 February. Now, the effect of the endometrioma and surgery on the fertility. You should know this because the prevalence and impact, because previous guidelines say whenever you see this endometrioma 4 and more, do cystectomy, but not now. So endometriosis is a chronic inflammatory condition affect the 10% of women of reproductive age. Out of this, 50% of the women is suffered with infertility. The contribution to infertility due to its pelvic adhesion, tubal blockage, and anatomical distortion. Because what happened when patient bleed on menses, same time she bleeds inside, and this lead to the adhesion formation and the scar formation. So that's why the total anatomy is distorted. Now, what found in ovarian endometrioma? Found up to 50% of women with the endometriosis. So remember, 10% is suffering with endometriosis. Out of this, 50% infertile and 50% have the ovarian endometrioma. Associated with reduced ovarian reserve. How you will do this? How you will check? Normally, if question came that how you will check the ovarian reserve, if they have given you FSH, AMH, AFC, we know that is the three things are there. So you have to choose FSH because RCOG always do the FSH. But in cases of endometrioma, it's better to do AMH and reduce antral follicle count. So antral follicle count. Always remember this because this is very common question in exam. That is how you will check the ovarian reserve. And everyone jump over the AMH. It is not. First investigation, initial investigation in RCOG, NHS is FSH. Because with FSH, we can divide the patient into three. Everybody knows WHO classification of amenorrhea, that is FSH. If it is highly elevated and estrogen is low, then patient is going in POI. Okay, normo, that means PCOD, which is the most common. And hypo, where the FSH is low and estrogen is low, this one it came in hypo type and it is treatable. Okay, that we have deviated from our topic, so we come on back. Woman with endometrioma has worse ovarian reserve than those with a normal ovary. Why? Because of surgical excision. So whenever you do the endometrioma surgery, you have to explain it to the patient. That is part 3 question. Further decrease ovarian reserve because risk is greater when both ovaries are involved. Surgery is repeated for recurrent endometriomas because whenever the patient doctors see laparoscopic surgeon, they do repeat surgery. But repeat surgery reduces patient reserve. Now, this is the pre-ART treatment which is given in the talk. So we are not going to discuss this because you just read it, not a problem. Management of endometriosis during ART. What things are required? Okay, so pituitary down regulation. Normally we are doing when we are starting IVF. Both GnRH analog can be used. So you can use any analog. Longer GnRH agonist may be considered for symptom control after surgery, but with caution in reduced. Remember this, because if you are giving the patient GnRH agonist, that is okay, then this reduce the symptom. But once you will stop it, it will recur. Ovarian stimulation, no one superior gonadotropin over other. So you can give recombinant, you can give urinary gonadotropin, both are same. Oocyte retrieval. Now this is important. What you are doing in IVF, uh, just a minute. IVF procedure is, what is the procedure in IVF? First of all, we do the ovarian stimulation. Okay, then we do the ovum pickup. Before that, we give the trigger. What is trigger? That is a HCG. Normally we are giving HCG, sometimes GnRH, whenever there is the chances of the, it's working. No, my pan is just charging. I will do this. So you give the HCG or GnRH. Whenever the patient have the risk factor for OHSS, we never give the HCG. Okay. Then second thing, you will give the GnRH or HCG. Then you do the pickup after 36 hours. And after that, IVF cycle will start. That is oocyte retrieval. So insufficient evidence for routine use of antibiotics should be considered with the endometrioma. So normally there's a question in exam that you have done the pickup. Now patient have the fever. Always remember, whenever we are doing the pickup, just cleaning the vagina with normal saline. Okay, we are not using any antibiotic. After pickup, there's no need to give the patient antibiotic. Even in endometrioma, not routinely. But when you will give, when you puncture the endometrioma. So elective aspiration of endometrioma at time of oocyte retrieval not recommended. When you will do this aspiration, when it is coming in your way, like this is the ovary, okay, these are your follicle, okay, and this is your endometrium, this is vagina, okay, you went from here and you are just want to pick up the ovum, okay, and then here you are not able to because this endometrium is in front of it, then this endometrioma you will aspirate that time, remember this, otherwise not. Fertilization, insufficient evidence to recommend ICSI over IVF with normal sperm parameter. What is ICSI? What is IVF? IVF, you are taking the, most of the people know this. That is, we take out the ovum and we just spread the washed semen over it and just keep into the, uh, in the lab. Okay. So fertilization occur by self. ICSI, what you are doing, intracytoplasmic sperm injection. You just hold the ovum and you will insert the sperm into it. Okay, so that is ICSI. Now, what is the difference? Live birth rate is same. Remember this because this is a question in exam. ICSI and IVF live birth rate is same, but the rate of fertilization is very high in ICSI because you are injecting directly sperm into it. So remember, it increases rate of fertilization, but not the live birth rate. Fertilization, insufficient evidence to recommend ICSI over this that we have done. Now luteal support. Always IVF patient, ICSI patient required luteal support, and we give the natural micronized progesterone. Insufficient evidence to recommend any particular luteal support to those with the endometriosis compared without endometriosis. So remember, support is same. Either you give in the endometriosis or without endometriosis. Frozen embryo transfer. Insufficient evidence to recommend natural, modified, or artificial with and without GnRH downregulation. So we don't have too much of the evidence. Now, management of the endometriosis prior to ART, that is no significant difference in live birth rate with or without, because this type of question is coming in exam. Either you give GnRH and agonist, hormonal contraceptive, role of suppressive therapy useful after surgery, previous symptom and recurrence. Remember this. Even you are doing the endometriosis surgery, okay, deep surgery nowadays people are doing. They will separate everything. They will show you ureter, they will show you nerves and all. After effect, we don't know because we have seen the surgery after 6 months, 1 year, patient have pain again. So patient always needs suppressive surgery, therapy after that. So you have to give her GnRH or you have to give her OCPs. Now surgery considered before ART. Now this is very important. Nowadays, if there is endometrioma is there, don't do anything. Mild to moderate endometriosis is there, then don't do anything. Not recommended. Severe endometriosis not recommended. That is before ART. So if patient is going for IVF, there's no need to do any surgery. But same case, if they have given you the patient have hydrosalpinx bilateral, then what you will do? Anyone answer? This is common question in exam. Yes, please.
Salpingectomy.
Yes, always remember when patient have hydrosalpinx, then we have to do the salpingectomy or clipping. Okay, like this. This is the uterus. Sorry, we have slide change. And now this is this. We have to either clip in here or you have to remove it. Why? Because the toxic fluid which goes through the salpinx to the uterus, it causes implantation failure. Okay, that is toxic to the embryo. That's why remember, if it is hydrosalpinx, you have to do clipping or you have to remove it. That is a salpingectomy, bilateral salpingectomy. But in endometrioma, no need to do any surgery now. That we will do again because SIP is coming. Surgery for endometrioma, ART consideration. Only one condition is there where you are not able to pick up the ovum. Okay. So ovarian reserve is reduced by surgical excision of the endometrioma. Now remember, ablation is better, excision is worst. So that is for ovarian reserve. Otherwise, if you will do recall old one, always answer is there. Do cystectomy. Okay, everyone jump on cystectomy. But now answer change. There is no strong evidence that excision improve the pregnancy outcome. Routine excision prior to ART is not recommended. So remember this, there's nothing to do before ART if there is endometriosis. Exception when surgery may consider to improve access for oocyte retrieval that I explained you already, that you are doing pickup. This is your ovary and these are your ovums and here is endometrioma. Vaginally you are reach here but you are not able to pick up. Okay, if you have assessed before, because in endometriosis, normally ovaries are fixed. Why? Because of adhesion and scarring. So that's why ovaries are not mobile. That is not that you will just push with the your TVS probe and it will move. It will not move. So that's why if you have assessed before, then do surgery before. Otherwise, that time you can do aspiration. That is a condition that you are doing that for symptom control when there is a pain is there. However, no definite size threshold can be recommended for surgery. Now, previously it is 4 and more, but now there is no 4 and more. If patient is symptomatic, you have to remove. If patient is not symptomatic, planning for fertility, don't do anything. Clinical approach management should be individualized, should involve minimal access surgeon, ideally conduct in the MDT setting. Now it came into the MDT setting. Now, management of endometrioma during endometriosis during ART, pituitary downregulation in ART, both GnRH analog, you can use agonist or antagonist are suitable options. No method show clear superiority over another. Oral progesterone do not outperform GnRH analog in women with the endometriosis. So you can use this. Ovarian stimulation, no evidence of superiority between, because nowadays they are telling recombinant gonadotropin is more effective. These are very expensive. Okay, so remember this: urinary gonadotropin, recombinant gonadotropin, human menopausal gonadotropin, everything have same effect. Oocyte retrieval in reserve of the in presence of endometrioma, that we have already discussed. Oocyte retrieval in presence of endometrioma, antibiotic should be considered to reduce the risk of. Now remember, when there is a pelvic infection, when tubo-ovarian abscess, especially if endometrioma is punctured. So this can be scenario that you have punctured the endometrioma, then give the antibiotic. Elective aspiration of endometrioma during oocyte retrieval is not recommended. But accidentally, if endometrioma is in front and your ovum is back, then you can aspirate. Otherwise, it is not elective. What is elective and emergency? Elective, that is pre-planned, like elective cesarean. I have decided I will do cesarean of my patient 2 days after. Emergency, she came suddenly and she have some emergency. So that is emergency. So in emergency, you can do. Fertilization, ICSI not superior to IVF in women with the endometriosis when semen parameter normal, that we have discussed already. Luteal support ART should be same for the woman without endometriosis. Frozen embryo transfer, no specific fat protocol recommended for women with endometriosis. So same, everything is same. Now this is a scientific impact paper, new paper released 4-5 days back, and it replaced the previous one. What is endometriosis? A condition where endometrial like tissue found outside the uterus, it may be ovary, bowel, bladder, causes chronic inflammation, pain, and can affect fertility. Now tell me, that is a question. Which is the most common organ affected by endometriosis? I think,
Ovaries.
yeah, ovaries. It is recall question. So remember, it's ovaries which are most commonly affected. We have already discussed 10% of the patient affected by endometriosis. Out of 50% have endometrioma. Out of 50% have infertility. So ovaries are the most affected organ. This is the recall. Epidemiology. Affect to 1 in 10 women in reproductive age, 10%. 30 to 50% subfertile, that we have done already. Now, what is a presentation of endometriosis? What they will give you in scenario so you can detect that is endometriosis. Anyone?
Painful periods,
Yes, painful periods. But what patient will give you? History. Severe painful
heavy, men-
periods. Yeah. And
heavy
it,
menstrual bleeding,
yeah.
heavy menstrual bleeding,
Yes, right. But she will give you every time she have severe painful period and it is increasing. Okay. Always remember, endometriosis is a progressive disease. If it is diagnosed at the age of 18, then it will progress further and causes the damage to the uh, 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 ovaries, uterus, adnexa, and all because of formation of adhesion. And patient have severity increases. So patient will give you a typical history. Doctor, I was suffering from 2 year, but nowadays it is increasing too much that I'm not able to go school. I'm not able to do my daily work. So that they will give you. So painful periods, dysmenorrhea, heavy menstrual bleeding, pain with the bowel movement or urination. So that is very important. The patient have the feel pain during because of the prostaglandin release. Remember, dyspareunia, that is a deep endometriosis when uterosacral is involved. Infertility, difficult in conceiving, that we have discussed. Some women remain asymptomatic despite having endometriosis. Care should be individualized, depend on symptom severity, fertility goal, and quality of life impact. Remember this, okay? Because we are going to do questions which are based on this. Diagnosis, which is the gold standard. Gold standard is always which one?
Microscopy.
Yeah, laparoscopy. Remember, before doing laparoscopy, that is the one thing you will explain to the patient. What? That is also question. That is part 3 also. That 50% time of the we don't found anything inside. Okay. But it does not mean there is no endometriosis. So remember, because microscopic lesions are there, which is also causing the pain. So it is diagnosed by transvaginal ultrasound, transabdominal ultrasound, and detection rate up to 90% with the routine ultrasound. Fertility implication: ovarian endometrioma can negatively affect ovarian reserve, egg count and quality, reduce chances of successful conception, require MDT approach to optimize the care. Fertility counseling and preservation: women with known endometriosis should be counseled or fertility preservation option early in care. Now remember, 18 to 20-year of age girl or 28-year-old age girl, she is coming to you and she is suffering from the endometriosis and not planning for the fertility. Then counseled her for fertility preservation because we know this disease is progressive. Treatment option: there's two type: expectant management, watch and wait, avoid surgical risk, preserve ovarian reserve. Surgical management, always laparoscopic keyhole surgery, can further reduce the ovarian reserve. Now, this is the difference. Potential benefit of expectant management: avoidance of surgery to associated complication, no further surgical compromised ovarian reserve, avoid delay in commencing assisted reproductive treatment. Surgical management: alleviation of the symptom, like patient is symptomatic, then you have to do it. Histological confirmation of diagnosis, exclusion of malignancy, reduce risk. I'm audible?
Yes, you're audible.
Suddenly sound went off. I'm audible now?
Yes, you're audible.
Okay. Okay. So we were discussing expectant management and surgical management.
But the video is not showing.
Slide is not showing. I will.
Now it is visible.
Okay.
Now it
So,
is visible.
okay. Thank you. So we are discussing expectant management, surgical management. Surgical management can we do for the symptomatic patient. histological confirmation of the disease to rule out the malignancy, because there's so many adhesion, there's a masses, so sometimes it look like malignancy on ultrasound. Reduce risk of cyst complication, facilitate ovarian access that we have discussed, ovum pickup. Potential harm, symptom pain is there in expectant management. Spontaneous cyst rupture can happen, that is the cyst accident. Difficult ovarian access during ovarian oocyte retrieval. Infection of endometrioma, follicular fluid contamination. No histological diagnosis. Always remember, it is confirmation by only by histology. Accelerated progression of endometriosis because it is a progressive disease. Surgical risk is there in surgery, reduce ovarian reserve, development of new post-operative pain symptom. Now remember this, because if you will remove endometriosis or endometrioma, there is adhesion formation. It can cause further pain. Post-operative adhesion, potentially delay of ART. Now, impact of endometrioma on fertility that we discussed already. Okay, that is it increases the it decreases AMH, sorry, not increase AMH and AFC. Okay, and toxic micro environment is there because of iron and ROS. Around the cyst, inflammatory peritoneal fluid may damage the follicle and gametes. Now, surgical versus expectant management, we already discussed, so we are not discussing. Effect of surgery, we discussed. Now, fertility outcome and surgery. So, spontaneous pregnancy rate post surgery can happen 30 to 50%. And always remember, whenever you do surgery for the endometriosis, you will tell the patient from next month she will try for the pregnancy, because disease is progressive. So always remember, particularly after unilateral cystectomy and careful selected women. Assisted reproduction also, most evidence show no improvement in pregnancy or live birth rate when surgery is performed. So don't do. That is RCOG say. Expectant management, uh, expert opinion and recommendation that they give same MDT approach. Surgery may be advised when endometrioma is more than 4 centimeter, symptomatic, interfering with ovarian access for ART. Patient prefer trying for spontaneous conception and accept potential ovarian reserve loss. So these are the only indication for surgery. So don't jump on more than 4 centimeter. She should be symptomatic. Expectant management better for asymptomatic patient, small cyst, and the adequate ovarian reserve. Pre-operative assessment for AMH AFC has helped personalized decision. Okay, and plan for fertility preservation. That is the egg freezing if needed. Now these are the different scenario. If symptomatic, large cyst more than equal to 4 centimeter endometrioma, you can consider laparoscopic surgery. Infertility without symptom, small endometrioma, expectant management preferred. Before IVF, small cyst, good reserve, don't do anything, just go for IVF. Bilateral endometrioma or recurrent surgery, then evaluate the patient for ovarian reserve. Now, takeaway is this, that is endometrioma hurt fertility both by damaging ovarian reserve via local inflammation. Surgery can offer benefit of symptom, relief, access to ovary, but carries a risk for reducing reserve. Spontaneous pregnancy rate post surgery are reasonable in selected women. Okay, it is in selected women, not all. No clear advantage of surgery before IVF. Decision should be personalized using AMH, AFC data, cyst size, symptom, and individual fertility plan. So that we are going to discuss. Now, this is the first question. A 32-year-old woman, 3 years of infertility, found to have unilateral 3.5 centimeter endometrioma. She is asymptomatic. AMH is normal. She is scheduled for undergo IVF. What is the most appropriate management? Now tell me.
Laparoscopic cystectomy.
I told you so many times.
Same, ma'am.
Yeah,
Same.
proceed with, yes, proceed with IVF
Proceed
without
with
surgery.
without
So
surgery.
always remember, if you are going for IVF and this cyst is not coming in between your ovum pickup, then no need of anything. Just proceed with IVF without surgery. Remember this, okay? Now, next, a 30-year-old woman present with chronic pelvic pain, dysmenorrhea. She has 6 centimeter left ovarian endometrioma. She wishes to conceive naturally. Now she wants to have baby naturally, okay? Don't want IVF. What is the most appropriate next step?
Laparoscopic cystectomy.
Yes.
C.
So remember this, in exam, they are giving you a big scenario, but they are giving you clue that you have to pick up. Okay. Because they have given you chronic pelvic pain, okay, dysmenorrhea. So patient is symptomatic. It's 6 centimeter, more than 4. Okay. And she wants conceive naturally. It is not IVF. If it is IVF, then
Ma'am, if it is not hampering with the ovum pickup, then we do not touch it.
go for IVF directly. Okay. So cystectomy is a preferred surgical approach. Though carries risk of reduced ovarian result. Now recurrent endometrioma, low MH. A 35-year-old woman have recurrent right ovarian endometrioma measuring 5 centimeter. AMH is only zero point 0.5 nanogram per ml. She is planning IVF. What is the most appropriate management now? Now what you will do?
Egg freezing before repeat surgery.
35-year-old lady. Egg
Ma'am,
freezing
egg
you will
freezing
do?
before repeat surgery.
No. You will do proceed with IVF without surgery. That we have discussed, that we are not doing anything if patient is going for the IVF. Okay. And she has recurrent ovarian endometrioma. That means she operated already and her reserve is low. AMH is zero point 0.5 only. Okay. And if you will do zero point 0.5 AMH, how many eggs you will get? Ovarian stimulation. Maybe 2, 3, 4 only. Or maybe 1. So that is very low. So remember, proceed with IVF without surgery. In women with low MH, recurrent endometrioma, further surgery risk further ovarian damage. IVF should be prioritized as surgery may worsen ovarian reserve without improving success rate. Now, bilateral endometrioma. This question. A 33-year-old woman with infertility has bilateral ovarian endometrioma. One is 4 centimeter, one is 5 centimeter. AMH is 2.1. Okay, she has mild pelvic pain. She want to conceive naturally. What is the best next step? Now tell me. This is
DNR
practical.
agonist therapy.
GnRH agonist therapy, if you will give, it will suppress it. Okay, but patient will not get the fertility. It will suppress fertility also.
Ma'am, laparoscopic cystectomy of both ovaries.
If you will do both ovaries, how much ovarian reserve will go down?
Ma'am, of 5 centimeter cyst. Laparoscopic cystectomy of larger cyst only.
Larger cyst only. So remember this, because the patient wants to have baby, she have mild pelvic pain. Okay, this is a clue. Conceived naturally. AMH is 2.1. Okay, if we are going to damage, we will remove these cysts. Maybe it will come to 1. So better to remove larger cyst. Don't touch simple a smaller cyst. Okay. So answer is this: laparoscopic cystectomy of the larger cyst. Explanation: in bilateral cases, full cystectomy on both ovary increased risk of ovarian insufficiency, because it can also happen. Removing large cysts may improve pain, fertility while minimizing reserve loss, and IVF may be considered later if natural conception fails. Now, adolescent with endometrioma. 19-year-old adolescent diagnosed with 4 centimeter unilateral endometrioma On pelvic ultrasound, during evaluation of dysmenorrhea, she is not sexually active, not planning pregnancy soon. What is the most appropriate management? Now, she is not she is having only dysmenorrhea, not sexually active, not planning pregnancy. You can give something for dysmenorrhea. Sorry,
Ma'am,
the
hormonal separation with OCP.
yes, very good. So give her hormonal preparation. OCPs give her, progestin give her. So it will suppress ovulation and there will be pain reduction. So first line for symptom control disease suppression is medical therapy. Always remember. Surgery is avoided unless refractory symptom concerning imaging finding develop. Now, this endometrioma affecting oocyte retrieval. A 34-year-old woman undergoing IVF has 5.5 centimeter left ovarian endometrioma. Her ovarian reserve is normal. The fertility specialist report difficult accessing follicle due to cyst. What is the next best step? Hint is in front. You are not able to go to the
Laparoscopic cystectomy.
yes. So always do laparoscopic cystectomy. Yeah, drainage you will not do. Remember that we have discussed already. In elective procedure, we will not do the drainage. But if it is in emergency that you don't know what is the size of endometrioma, where it is situated, and when you are doing pickup and it comes front, then you can drain only. Otherwise, for elective procedure, best procedure is do cystectomy. So, laparoscopic cystectomy, if endometrioma interfere with the follicle access during IVF, surgical removal may be justified. Improve access outcome, especially if cyst is large. Okay. However, care must be taken to minimize the ovarian reserve. Endometrioma and recurrent surgery. Now, this a 38-year-old woman, 38, okay, history of bilateral endometrioma surgery. She now present with recurrence of both side and infertility. AMH is 0.8. Now, what you will do? She's 38, even for the
Ma'am, IVF
infertility.
without surgery.
without further surgery.
Okay, very good. Now there's a two questions are coming in the exam. Okay, one is the 28-year-old girl. She came for the primary infertility. Okay, she is trying from the last 6 months or last 1 year. Now, what you will advise her? Common questions of fertility, if you have read. And same question. She is 38-year-old and she is trying from the last 1 year for the fertility. Now, what you will do? Only age can change the answer. So, this patient, because RCOG always say that if you are
That you can
trying,
wait for 1 year.
yes, and this one, she already tried
Ma'am,
for 1 year.
IVF. Ma'am,
Yes,
So
IVF.
you
she did.
have to do IVF.
Why IVF in 38 years?
Ma'am, her
You know,
reserve is low.
no. If reserve rate is low, they will not give the her IVF
Egg donation.
because NHS funding is giving. If patient will reach at the age of 40, they will give the single IVF cycle. Remember this. And if you will start at 38, then she can get at least two. So that is the reason, okay? So proceed with IVF without further surgery. Now, which surgical technique? A reproductive surgeon is planning laparoscopic removal of 4.5 centimeter unilateral endometrioma. 29-year-old woman wishing to conceive. which surgical approach is most likely to preserve ovarian reserve? Now tell me which is the best one.
Laser ablation.
Yes, so remember this, laser ablation or combined technique is the best one, even doing cystectomy. So that is the best one. Laser vaporization ablation associated with less loss of the ovarian tissue compared to cystectomy. Or you can use the combined approach. You use a laser with cystectomy. Okay. Now, asymptomatic patient, a 30-year-old woman with regular cycle found to have 3 centimeter right ovarian endometrioma on ultrasound. She is trying to conceive naturally and asymptomatic. AMH is 3.2. What is the most appropriate next step? Asymptomatic, we have done.
C.
Yeah,
Ma'am,
expectant
expected
management.
management.
C.
Yeah, nothing to do. That is expectant management. A good ovarian reserve, expectant management is preferred. Surgery isn't recommended unless symptom develop or conception fail after 6 to 12 months. So tell her to try at least for 1 year. Now, egg freezing consideration. A 33-year-old woman with 4 centimeter unilateral endometrioma has not yet decided about pregnancy but concerned about her future fertility. AMH is 2.8. She is asymptomatic. What is most appropriate next step? Now she is 33, not planning, and she already have endometrioma 4 centimeter. What you will advise?
Do nothing unless symptoms arise.
We have topic also here. You will tell the patient do for the oocyte cryopreservation because she is already 33-year age. If endometriosis endometrioma will increase, AMH will decrease as well as the oocyte quality will decrease. So that is the one. For women not ready for conceive but concerned about future fertility, egg freezing may be offered because any surgery, ovarian damage occur. Early fertility preservation is appropriate option. Now, this is the last question. I think it is EMQ. What we have done already. Okay. A 30-year-old woman with infertility has a 3 centimeter unilateral endometrioma, asymptomatic, has normal AMH. She has been trying to conceive for 6 months, prefer natural conception. 30-year, 3 centimeter, asymptomatic, normal AMH, 6 months. These are the clue.
Ma'am,
What?
expected management.
Yes,
B.
best is
Expected management.
yes, very good. A 33-year-old woman, recurrent 6 centimeter endometrioma, left ovary, AMH 0.9. She had cystectomy 2 years ago. Now she is planning for IVF. We have
Proceed
done
IVF without surgery.
very good. Proceed IVF without surgery. 28-year-old woman present with 5 centimeter painful endometrioma has not yet tried to conceive. AMH 3, she preferred natural conception but has severe dysmenorrhea.
Ma'am, then laparoscopic cystectomy.
You will do cystectomy or combined excision and ablation.
Ma'am, combined excision and ablation.
Okay, we'll see what is the answer. A
F.
34-year-old woman with
F. F.
bilateral 5 cent because it preserves the ovarian reserve. Okay, so remember this. If laser ablation is there, it's the best answer to preserve the ovarian reserve. A 34-year-old woman with bilateral 5 centimeter endometrioma planning IVF. One ovary is poorly visible due to cyst. Her AMH is normal. Reproductive specialists express concern about access to follicle during egg retrieval. Egg retrieval, it is difficult.
Ma'am, here we have to do laparoscopic cystectomy.
Yes. A 26-year-old woman not currently trying to conceive is found to have 4 centimeter endometrioma. She has no symptom but concern about her future fertility and ovarian reserve. Always remember what patient wants. That is important.
Egg freezing. E.
Yes. So here is this because she has no symptom but concern about her future fertility and ovarian reserve. So that is her concern. So you have to give answer for that. And she is 26. So you can discuss with the egg freezing. Now we check the answer. That is this. They have given bilateral is the compare. Okay. So answer is correct. Now these are our classes schedule. Date is not given. If these are our mock series, which is included, we have more than 5,000 questions and the fee is $450. If anybody wants to join, please contact this number and email because we are going to start from 15th August and we are going to discuss question based only because I am providing all the recordings before whatever recording we have. So you can listen that and then later on we can discuss a question. So any question? No. Okay. Good night.